Welcome to Pathology Central Key Concepts. The topic of this video is adrenocortical hyper and hypofunction. I'm going to begin with a brief overview of the adrenal gland, and then we're going to focus on the syndromes associated with hyperfunction of the adrenal cortex, so Cushing's syndrome, hyperaldosteronism, and the adrenogenital syndromes. Next, we'll be looking at hypofunction of the adrenal cortex with acute and chronic adrenal insufficiency. Here we have a beautiful histologic image of a happy, healthy adrenal gland cortex. We have the adrenal capsule here, and beneath that the zona glomerulosa, where mineralocorticoids are formed. Here we'll be thinking about aldosterone. Beneath that is this thick layer composed of lipid-laden, fluffy cells, which generate the glucocorticoids, so cortisol. And finally, closest to the medulla will be the zona reticularis, where sex steroids are formed. The medulla will be hanging out underneath here, forming catecholamines and the site where pheochromocytomas can arise. So what regulates this hormone production? Well, as with so many things, it will be our hypothalamus. So when the hypothalamus senses the need to produce these hormones, it is going to release CRH, corticotropin-releasing hormone. Now, this image here is a little bit simplified, so we're going to expand it here and recognize that what CRH says to the anterior pituitary is to make pre-pro-opiomelanocortin, which is then cleaved to yield pro-opiomelanocortin, or POMC. Now, POMC is an old friend whom we discussed in the environmental section when we were talking about energy balance. Now, POMC can be cleaved into a variety of peptide hormones, and the two that are most important for this video will be ACTH, adrenocorticotropin hormone, and alpha melanocyte stimulating hormone, or MSH, which will have a cameo later in the talk. All right, so our three syndromes we're going to be looking at when we think about hyperadrenalism will be Cushing syndrome, cortisol excess, hyperaldosteronism, aldosterone excess, and the adrenogenital syndromes, sex hormone excess. So let's begin with Cushing's syndrome. So Cushing's syndrome, as I said, is due to excess cortisol. And the most common cause of this is going to be exogenous cortisol administration, iatrogenic, patients who are taking medications. This is the most common cause of hypercortisolism. Now, there are, of course, endogenous causes of Cushing's syndrome as well, and we divide these as ACTH-dependent and ACTH-independent. Now, the ACTH-dependent ones are ones in which you have excess ACTH in the body, which is going to drive the adrenal gland to cortical hyperplasia. The two primary causes of this will be Cushing disease, which is caused by an ACTH secreting pituitary adenoma, so that's about 60 to 70% of cases of Cushing syndrome, and paraneoplastic ACTH secretion. So this will be when you have some sort of malignancy, for example, small cell carcinoma of lung, that is ectopically secreting ACTH, which will then stimulate the adrenal gland, cortical hyperplasia, increased cortisol. Now, the ACTH-independent Cushing syndrome is when the adrenal gland is free from external regulation, and this can be through a primary adrenal neoplasm, adenomas more common than carcinomas, or through nodular adrenocortical hyperplasia. Now, here's a nice image that puts that all together. So remember, when you're thinking you have a patient with Cushing syndrome, the most common cause of this is going to be iatrogenic, so a patient taking steroids. Now, when that patient takes steroids, what will happen is there will be decreased ACTH levels because there's no need to stimulate the adrenal gland to form steroids because they're already loose in the body. So you'll get adrenal gland atrophy. So you can see that here in this image. Now, the endogenous causes of Cushing syndrome, as I mentioned, are either ACTH-dependent or ACTH-independent. So once more, the most common cause of ACTH-dependent Cushing syndrome is actually Cushing disease, which is a pituitary adenoma generating abundant ACTH, stimulating that adrenal cortex, pumping out cortisol. Another cause, of course, is our paraneoplastic Cushing syndrome. Here you can see a small cell carcinoma of lung, which is generating ACTH, causing adrenal hyperplasia and cortisol. And finally, when you have the lack of regulation, this is there's no feedback inhibition, we have our adenoma or a carcinoma generating cortisol, or our nodular hyperplasia. Now let's take a look at what this we see grossly. First, we have a normal, happy, healthy adrenal gland with the yellow colored cortex. It's yellow because of abundant lipid. the medulla here, where our pheochromocytomas can arise. Here we have ACTH-dependent Cushing syndrome. So remember, you have a lot of ACTH, perhaps from that pituitary adenoma. It's coming down to the adrenal gland. The cells are saying we need to start generating hormones, so they plump up and they're putting out lots of cortisol. Now, ACTH independent can be micronodular or macronodular hyperplasia. And you can see here in this example, we have these nodules. They're darkly pigmented. It's thought that this is due to lipofuscin. And here's an example of an adrenocortical adenoma, which once more has that abundant lipid and therefore has this yellow appearance. So this as well is ACTH independent. Okay, so how do you assess a patient whom you suspect of having Cushing syndrome? And the next slide I'll go over the clinical presentation. But let's just say you have a suspicion that this patient might have Cushing syndrome. The first thing you're going to want to do is a 24-hour urine-free cortisol concentration to let you know how much cortisol is being generated. Now, another thing that's important is, as you'll recall, there is a diurnal pattern of cortisol secretion, where we have a peak of cortisol when we first get up and then a trough later in the evening. And when you have Cushing syndrome, you will lose this normal diurnal pattern. So if you're to do, say, a salivary measure of ACTH and you see there is no variation, this will help you to know that this is Cushing syndrome. Now, once you've identified a patient as having Cushing syndrome, the next thing you have to determine is, why does this patient have Cushing syndrome? So the first thing you'll do there is to check a serum ACTH, and I'll go through why that helps you distinguish. And the other thing you want to do is you want to see whether, if you administer external exogenous steroids, you can suppress the production of cortisol. So what you'll do is you'll give either low or high dose dexamethasone, and you'll measure the urine steroids to see if this has had an effect of diminishing the production of steroids by the patient. So let's look at 3 examples of Cushing syndrome and see how these tests help us to identify them. So if you have a pituitary adenoma that's secreting ACTH, obviously your ACTH levels will be high. And if you give a low dose of dexamethasone, that will not be sufficient to suppress cortisol formation. However, if you give a high dose, that will be enough to overcome the generation of pituitary to suppress that. So you'll get your feedback inhibition with high dose dexamethasone. Now, by contrast, if you have ectopic ACTH secretion, so for example, in our paraneoplastic syndrome, you're once more, of course, going to have increased ACTH, but no matter how much dexamethasone you give, it will not suppress, because this is outside of the adrenal pituitary axis. And finally, if you have adrenal hyperplasia or a tumor, then the adrenal gland is acting independently. It's generating lots of cortisol. That feeds back to the hypothalamus and to the pituitary gland that says, oh, we don't need to make ACTH. We have plenty of cortisol. So when you give low or high dose dexamethasone, it's not affecting that axis. It's already depressed. All right, so that brings us to that. Let's now talk about how you might recognize a patient with Cushing syndrome, as well as what are some of the side effects and downstream effects of cortisol excess. So one of the classic features of Cushing syndrome will be weight gain. This is going to be predominantly through truncal obesity. Patients will develop fat deposits in the face. It's referred to as moon faces. I'll show you an image on the next slide. And they can also get fat deposition on the posterior neck and back. Patients with cortisol excess will get atrophy of specifically type 2 or fast twitch myofibers, which will decrease muscle mass and lead to proximal limb weakness. Furthermore, cortisol increases gluconeogenesis while decreasing glucose uptake into cells. This will lead to hyperglycemia, glucosuria, polydipsia. You might be thinking these are symptoms that we see with diabetes. Cortisol also has catabolic effects, so we're going to get collagen loss and bone resorption. Now, collagen loss is going to manifest as easy bruising, delayed wound healing, and cutaneous striae. Again, I'll show you a picture of that on the next slide. And patients on long-term steroid use, for example, autoimmune hepatitis, may have osteoporosis, so something to be aware of for those patients. Cortisol is immunosuppressant, so patients will have an increased risk of infection. And there will also is a possibility of mental disturbances, so mood swings, irritability, depression, even frank psychosis. Additional findings in Cushing syndrome are hirsutism and menstrual abnormalities. Now let's take a look at a patient with Cushing syndrome where you can see this fat deposition on the face. This is referred to as moon faces. You see the truncal obesity here, and then these are the characteristic striae that we can see. All right, so that wraps up for us Cushing's syndrome. Let's now move on to hyperaldosteronism. So we always like to divide things up, make it easier to digest. We have primary hyperaldosteronism and secondary hyperaldosteronism. Now the most common cause of that will be bilateral idiopathic hyperaldosteronism, and this is due to bilateral nodular hyperplasia. The second most common cause will be an adrenocortical neoplasm, and that will be an adenoma about 35% of the time, and in that setting, this is referred to as Cushing's syndrome. Finally, there are rare cases of familial hyperaldosteronism. Now, you can get secondary hyperaldosteronism if you have increased plasma renin. Now, remember, you have the renin-angiotensin-aldosterone system that as renin goes up, that's going to stimulate secretion of aldosterone. So if you have anything that's going to cause plasma renin to increase, you're going to get increased aldosterone. So if you have decreased renal perfusion, such as an arteriolar nephrosclerosis or renal artery sclerosis, that can lead to increased plasma renin. Anytime that you have arterial hypervolemia and edema, this is going to be perhaps due to congestive heart failure, cirrhosis, nephrotic syndrome, or this can lead to increased plasma renin. And finally, pregnancy can result in hyperaldosteronism due to estrogen-induced plasma renin substrate increase. Okay, so what is the effect of all this aldosterone on the blood or on the body? Okay, so once more we have here our primary causes. Most common, idiopathic hyperaldosteronism. Second most common will be our adenoma, and then we have our secondary causes, all of them leading to increased aldosterone. What does aldosterone do? Well, it's going to move potassium from the bloodstream to the renal tubule for excretion, so we'll have potassium wasting. And this can have neuromuscular manifestations such as weakness, paresthesias, and tetany. The same time that we're wasting our potassium, we're holding on to our sodium, so reabsorbing it from the tubular urine back into the bloodstream. This can lead to hypertension, ultimately to congestive heart failure. All right. So that takes us through hyperaldosteronism. Let's talk about our last hyperfunction of the adrenal cortex, the adrenogenital syndromes. So as you recall, as we discussed, the adrenal cortex secretes sex hormones as well. So dihydroepiandrosterone and androstenedione, which can be peripherally converted to testosterone. The secretion of these two is regulated by ACTH. Now, when we think about the adrenogenital syndromes, what we're really going to be focusing on is congenital adrenal hyperplasia. Now, what these are is a group of autosomal recessive metabolic disorders that are due to some enzyme deficiency in the production of cortisol or aldosterone or both. And depending on the mutation, you can see a variety, just sort of a range of effects. Now, the most commonly mutated is going to be 21-hydroxylase deficiency. That's must be the most common cause of congenital adrenal hyperplasia. So what happens is when you have that enzyme deficiency, the substrate, those precursors, are going to build up behind the defective step. And in this particular syndrome, those substrates can now be channeled to a different pathway, leading to androgen production and virilization. Now, because we have a block in cortisol production, we're not getting that feedback inhibition, and we're going to get an increase in ACTH secreted by the pituitary gland, leading to adrenal hyperplasia, as the adrenal gland is trying again and again to make more cortisol. If you have, and depending on the degree of aldosterone secretion you have, you can get salt wasting. So let's take a look at this pathway. All right, so our hypothalamus has sensed that there is a decrease in glucocorticoids and mineralocorticoids, says to the pituitary gland, make ACTH. The adrenal gland becomes hyperplastic because it's not able to make these. So there's this feedback loop that just keeps going around. So what happens? We go from cholesterol, we're moving through our pathway trying to get to aldosterone. When we get to progesterone, because we're lacking 21-hydroxylase, this substrate progesterone is going to build up. It can't go down to make aldosterone. It can then shunt over into this pathway, which would ideally take you down to glucocorticoids, but again, we have a block in 21-hydroxylase, so we're not able to progress down to cortisol. So all of this substrate is now going to shunt over here, leading to the production of our sex steroids, increased sex steroids, decreased glucocorticoids, decreased mineralocorticoids. This deficiency in this signals back to the hypothalamus and to our pituitary gland, make ACTH, and we just keep going round and round. Okay, so what do you see with 21-hydroxylase deficiency? As I mentioned, it depends on how badly the enzyme is affected. So if you have a total lack of 21-hydroxylase, then you get no synthesis of the mineralocorticoids. This can lead to a salt wasting syndrome that can be very dangerous for the patient. Now, about a third of patients with 21-hydroxylase deficiency are able to generate sufficient mineralocorticoids, but they still are not generating cortisol. So this is referred to as simple virilizing adrenogenital syndrome without salt wasting. Now, because they have decreased cortisol, we're going to increase our ACTH, and we're going to keep generating more and more substrate, shunting over, generating more testosterone, leading to this virilization. And then finally, the most commonly seen will be a partial deficiency of 21-hydroxylase. And this is going to lead to non-classic late-onset adrenal virilization. These patients are able to get some mineralocorticoids, some cortisol made, so we'll have milder symptoms, for example, hirsutism, acne, menstrual irregularities, and this may not present until puberty. Okay, so that brings us finally to the end of our hyperadrenalism. Let's now talk about hypoadrenalism. Okay, so the opposite end of the spectrum. Now we'll look at this in the context of acute adrenocortical insufficiency and chronic adrenocortical insufficiency, or Addison disease. So acute adrenocortical insufficiency can be seen primarily in three scenarios. So if you have a patient who's on long-term corticosteroid therapy, for example, again, autoimmune hepatitis, and you abruptly withdraw those steroids, the patient can go into acute adrenal crisis. Now, why would a patient abruptly withdraw from this therapy? Maybe they don't like the symptoms that they're developing that I showed you earlier that are associated with cortisol excess. Maybe they've run out of medication. Maybe they can't afford their medication. This is why we always taper when we give patients corticosteroids. Another cause of acute adrenocortical insufficiency is someone who has an underlying chronic adrenocortical insufficiency. They're doing all right, they're managed, but then they have an additional stressor on top of that, like an infection or trauma or surgery, that pushes them into adrenocortical insufficiency. And finally, you can have massive adrenal hemorrhage, which when you get to a certain point is going to just wipe out the adrenal glands, and when that happens, you can have acute hypoadrenalism. And the primary causes of this will be disseminated intravascular coagulation. You can see it in patients who are on anticoagulation therapy, and then also in the setting of Waterhouse-Friderichsen syndrome, which we'll talk about on the next slide. But next, let's talk about chronic adrenocortical insufficiency, or Addison disease. Now, this is in higher resource countries is most commonly due to autoimmune adrenalitis, so about 60 to 70% of cases. In lower resource countries, we see a higher incidence of infectious causes, so tuberculosis, for example, or AIDS or fungal infection. There are systemic diseases as well that can contribute to hypoadrenalism, so hemochromatosis, sarcoidosis, and systemic amyloidosis. And finally, metastatic disease, so carcinomas of lung and breast, are the most common causes of chronic adrenocortical insufficiency from malignancy. Now let's take a moment to go back here to Waterhouse-Friderichsen syndrome, because it's a term that you may see on the wards or probably more commonly on the boards. So let's talk about what that is. So Waterhouse-Friderichsen syndrome is what you see. We have bilateral massive adrenal hemorrhage, and it's in the setting of overwhelming bacterial infection. Now, you'll be taught in your review books that the most common cause is Neisseria meningitidis, but actually you can see it with a variety of different infectious agents, so Pseudomonas, Strep pneumo, and gonorrhea, and E. coli. So don't just be fixated on N. meningitidis when you're treating patients on the wards. What happens is, with this overwhelming bacterial infection, we get rapidly progressive hypotension and shock. This can lead to disseminated intravascular coagulation with purpura, which you'll see on your patient. They'll have these large bruises developing in their skin. And then at this point, you can get massive bilateral adrenal hemorrhage, leading to rapidly developing adrenocortical insufficiency. Now, just a trigger alert, I'm going to show a picture on the next slide. If you're watching this with friends or out in the public, you may want to ask them to avert their gaze. This is a patient who died of Waterhouse-Friderichsen syndrome, and you can see here these purpura here of the face. This is an image from a different patient showing that the adrenal gland has got this massive hemorrhage where you have loss of the adrenocortical architecture. And they'll refer to these grossly as being just like sacs of blood. So what are the clinical findings in patients with acute and chronic adrenocortical insufficiency? So in acute adrenocortical insufficiency, we call this acute adrenal crisis. Patient can present with intractable vomiting, abdominal pain, hypotension, coma, vascular collapse, and death. So you need to be aware and have a high index of suspicion if you have a patient who is a setup for this, for example, with sepsis, and they need to get the appropriate hormone support. Now, chronic adrenocortical insufficiency is actually harder to recognize because it can present with nonspecific findings such as progressive weakness or fatigability. There can be GI symptoms such as anorexia, nausea, vomiting, diarrhea, and weight loss. Now, as you recall, with decreased glucocorticoids, you'll get decreased gluconeogenesis. Instead of what we saw with cortisol excess, we're going to get hypoglycemia. Now, I just want to finish up by talking about the difference we see with primary adrenal disease, right? So we talked a little bit about secondary adrenal disease and primary adrenal disease. If we have primary adrenal disease and we have insufficiency, we're going to get increased ACTH production. Remember, the adrenal glands are speaking to the hypothalamus and saying, let's make ACTH, let's make cortisol. And what will happen, as you'll recall, is this ACTH prohormone, pro-opiomelanocortin, or POMC, can break down, or it can be cleaved to form ACTH and melanocyte-stimulating hormone, which is going to do what? Stimulate melanocytes. And this is going to cause skin hyperpigmentation or bronzing, so of the sun-exposed skin in areas where there's friction. Another thing that we can see with primary adrenal disease is we can have decreased mineralocorticoids. So in contrast to what we saw with hyperaldosteronism, we're going to get potassium retention, not potassium wasting, and sodium loss, not sodium retention, leading to hyperkalemia and hyponatremia, volume depletion, and hypotension. All right, as always, I'm going to finish with some questions. You can go ahead and pause this, take a look, and see what it is that you've learned in the last 20 minutes or so. And as always, I'd like to thank you very much for your time and attention. Please let me know if this worked for you, if you have any comments, and you can reach me on Twitter. So thank you very much.